Good morning all. In previous class we had seen regarding the various genital tract injuries, that is obstetrical legacies leading to gross gynecological problems. Then what do you mean by CPT, that is complete perineal tear definition we had seen. Then classification, etiological factors, obstetrical and gynecological. Then risk factors we had seen. Then structures shown in CPT. Then the clinical features we had seen, symptoms, signs, then what is the inference of palpation, then in treatment we had seen regarding the preventive. So in this video we will be dealing with the operative, that is what are the things coming under the operative treatment. So the definitive surgery is repair of the anal sphincter complex, so that is called as sphincteroplasty, with the restoration of the perineal body, that is perineorrhaphy, and this should preferably be done between 3 to 6 months following the injury. The best time of repair is, however, within 24 hours of the injury. By 3 months' time, the local infection subsides, general condition of the patient improves, and the baby can be kept at home. If kept more than 6 months, there is more fibrosis on the margins and unnecessary prolonged inconvenience to the patient. So best time is soon after the injury we have to do the surgery. And if we keep on up to 6 months, what will be happening? There will be fibrosis on the margins and unnecessary prolonged inconvenience for the patient will occur. And pre-operative investigations, there is no special pre-operative investigation except the stool should be examined for evidence of intestinal infestations like hookworms, ascaris, or E. histolytica, which are rampant in the tropical countries, and their presence needs eradication prior to the surgery. So prior to the surgery we have to see regarding whether she have any of the infestations, and if anything is there like that, we have to first eradicate that one, then you have to go for the surgery. Then what are the pre-operative preparation have to do? The patient is admitted at least 3 days prior to the surgery. The patient should have a low residual diet consisting of milk, bread, lime, and only 2 days prior to the surgery. Then intestinal antiseptics are prescribed starting from 2 days prior to the surgery, and any one of the drugs may be given, that is either neomycin 250 mg thrice daily, or erythromycin 500 mg thrice daily, or metronidazole 400 mg thrice daily. Enema and bowel wash are given daily for 2 days prior to the operation, and the idea is to clear the lower bowel, and enema should not be given in the morning of the operation. Then the principles of surgery, that is wear and flap method. An inverted V-shaped incision is made on the posterior vaginal mucosa. I will show you the picture. So you can see the picture. And second step is mobilization of the rectal wall from the overlying vaginal wall. Then mobilization of the torn ends of the sphincter ani externus. Suturing of the rectal wall in 2 layers. Approximation of the torn ends of the sphincter by interrupted sutures. Then apposition of the musculofacial structures of the perineal body by 2 to 3 interrupted sutures. Apposition of the vaginal wall and skin of the perineum by interrupted sutures. Next we will see regarding the steps of operation. So preliminaries as in anterior colporrhaphy, the actual steps, that is mobilization of the rectum and anal sphincter we are doing. For that 2 Alice tissue forceps are placed on either side of the fused rectovaginal mucosa and are retracted laterally by the assistant. An inverted V-shaped incision is made over the fused mucosa extending from one end to the other. 2 Alice forceps are placed on either side of the lower end of the labia minus. Incision over the fused mucosa is extended upwards from each end of the to the lower end of the labia minus. The posterior vaginal wall is dissected off from the rectum and the rectum is well mobilized. 2 more Alice forceps are placed beyond the skin dimple on either side. Incision is made from each end of the fused mucosa downwards over the skin dimple, site of the torn end of the sphincter ani externus. So you can see picture 3. They have made the incision. Then you can see the Ali's forceps. They have scald. And the incision lines now look almost to the letter H. The torn end of the anal sphincter of each side is held by Ali's forceps and is well mobilized. In picture 4 you can see that is torn end of the anal sphincter of each side is held by Ali's forceps and it is well mobilized. Next we will see regarding the repair. Prior to repair, the scar tissue on the rectal margins is to be excised. The rectal wall is sutured by interrupted sutures using polydioxanone 30 on 30 mm needle starting from the apex, and the knots are placed inside the lumen. The pararectal fascia is approximated over the first layer by interrupted sutures using the same suture material. Then sphincteroplasty. The torn ends of the sphincter ani externus are approximated in front of the repaired rectum by a figure of 8 suture using polydioxanone number 2 to 0. This is enforced by 1 or 2 interrupted sutures, and result of repair of EAS either by an overlapping or an end-to-end approximation method are the same. Then redundant portion of the vaginal mucosa is excised. 2 or 3 interrupted sutures are placed through the fibromuscular tissues of the perineal body using Vickrell number 0, and the rest of the steps are like that of perineography. Special postoperative care. So after the surgery, non-residual diet is given from 3rd day onwards and the full diet is given on 6th day. Bowel should not be moved for about 4 to 5 days. Lactulose 10 ml twice daily beginning on the 2nd day and increasing the dose up to 30 ml on the 3rd day is a satisfactory regimen to soften the stool. If the patient fails to pass stool and it is having discomfort, compound enema, that is olive oil or liquid paraffin or glycerin and normal saline each 4 hours may be given by a rubber catheter. Antibiotics like cefuroxime 1.5 and metronidazole 500 mg IV are used to cover the perioperative period. Intestinal antiseptics should be continued for about 5 days. What are the advice we are giving on discharge? Stool is kept soft using a laxative at bedtime. Contraceptive practice to postpone the pregnancy, to review the woman after 6 weeks of repair, to have antenatal checkup when she is pregnant, and a mandatory hospital delivery in future vaginal delivery, and liberal mediolateral episiotomy may be done. Women who are symptomatic or have abnormal endoanal USG and or manometry after repair should be delivered by elective cesarean section. What are the complications of repair operations? There will be complete dehiscence, incomplete dehiscence leading to rectovaginal fistulas, difficulty in defecation because of too much tightening of the sphincter, dyspareunia, persistence of incontinence of flatus or feces, endoanal USG or anorectal manometry is to be done to detect any residual defects. So in next video we will be discussing regarding the coital injuries. Hope you understood regarding this. So please subscribe and share to your friends. Watch next video also. Thank you.